So welcome to all of you, and thank you very much for coming out on a Thursday evening just before Christmas. My name is Sarah Bennett. I'm an associate professor at Johns Hopkins School of Public Health. And this is a meeting of the Health Systems Board. And I know that some of you have been to Health Systems Board meetings before, but not all of you have. The Health Systems Board was actually established in 2008, but we have been trying to re-energize it recently. And it really aims to serve as a forum for all those professionals in the greater Washington area who have an interest in health systems and policies around health systems. So if you're not already on the mailing list and you're interested in this field, and then I think that there will be a sign-up sheet circulating, so please do add your name to the sign-up sheet. I'm really delighted tonight to be able to introduce Dr. Ariel Pablos-Mendez, who's the Assistant Administrator for Global Health at USAID. And I actually know Ariel going back to WHO. I guess it's not that long ago, sort of 5 or 6 years ago, when Ariel was Director of the Knowledge Management Department at WHO. More recently, he was Managing Director at the Rockefeller Foundation in charge of the Rockefellers' health portfolio, and has joined USAID in September. Yes? August. So you've had all of
4 months.
16 weeks to sort out the issues and the path ahead. And Ariel's a Mexican citizen. He's also a clinician internist by training. Ariel is going to open by, I think, sort of talking about some of the issues that he sees in terms of USAID leadership and health systems in the future. But we thought it might be nice if we went very quickly around the room and if people could just say their name and which organization they're affiliated with, just so that Ariel has a sense of who's at the table. And I also have to admit that I don't know everyone here, so it would be great if we had a slightly better sense of who is here. So maybe I could ask you to start, Derek.
I'm Derek Winkerhoff with RTI International, and I work on the Health Systems 2020 project out of the Hidden Office.
My name is Lydia Pina, and I'm a PhD student at Johns Hopkins School of Public Health.
Hi, I'm Crystal, and I work for IntraHealth International on Capacity Plus Project, Human Resources for Health.
Daniela Louie with Johns Hopkins School of Public Health and Health Systems.
Great. Gavin Gregor Skinner, Penn State University. I work on the World Campus platform for creating functional effective networks.
Should we go to the people behind you?
Sure. Kevin Croak, I'm adjunct professor here at SAIS and World Bank.
Michelle Geis, I'm in the MPH program at Hopkins and Systems.
I'm Alice Garibrandt. I work with Results for Development Institute on the Joint Learning Network for Universal Health Coverage, and previously worked with Ariel on that.
I'm Danica Demoska, Results for Development as well, working on government innovations, which Ariel is very familiar with.
Elaine Yuan, working in the USP PQM program, just on the season.
Karen Kavanagh, USAID.
Christoph Gorski, coming from the World Bank, I'm the Sector Coordinator for Human Development for Europe and Central Asia.
Jeremy Schiffman, I'm faculty at American University, and I do research on global health advocacy.
Douglas Clendon, Apt Associates, also working on the Health Systems 2020 project, like Derek and some other folks here.
Greg Nakano, Center for Disaster and Humanitarian Assistance Medicine.
Jonah Moeller, USAID.
Robert Clay, Deputy Assistant Administrator for Global Health at USAID.
Marty Makinen, Results for Development Institute.
Marcel Ricoeur, Health Group at Millennium Challenge Corporation.
Bob Emery with USAID's Global Health Group.
Erin Chavone, Apt Associates, and I work on the Health Systems 2020 project.
Liz Nugent, Apt Associates, also Health Systems 2020.
Mariana Corey, also Health Systems 2020 project.
Hi, Catherine Connor, Deputy on Health Systems 2020.
Ann Lyons, Project Director of Health Systems 2020.
Lynn Franco with Encompass.
Gio Franco, MSH.
So, Ariel, I understand we'll talk for, 20 minutes, 30 minutes. Do you want us to interrupt you, or would you prefer that you had a clean run at it?
Anyway, I feel that really, almost among family with so many people that I know, and in the taxi, I think Bob Emery was commenting that he didn't know how, but suddenly in one of the bills from the Congress, there was a specific mention of Assistance 2020, and I can see now why so many people in Washington are here on Assistance 2020. That's great to meet many of you, and it's also great to see a balance of sort of the old guard when this issue was not a top agenda, as Jeremy has studied, and but also to see many young faces, and I think that's a great sign for the health systems field, and Sarah has been there all along. And although she started when she was born, right? But the last 20 years, I think, has been particularly important in this field. So I thank you. I'm very pleased to be here, and I also discussed whether to bring PowerPoints, and maybe it would have been a good idea in this crowd, but I'm getting used to giving speeches, so I have now my remarks, and we can just play it as we go. I really want to make sure that we get to share with you where we've been, where we are. Many of you will know it well. Others may learn, but I hope that you can also give us your views, your ideas, your suggestions as we move to a new stage in our work. And I want to thank, of course, Sarah and Johns Hopkins University, I guess DFID to some extent also, and for the support that they have for this group, for this type of exchanges. On World AIDS Days, just very recently, President Obama spoke at an event titled The Beginning of the End of AIDS. And he outlined the role of the United States will play in achieving an AIDS-free generation, one of the 3 pillars of the U.S. government strategy in global health. And as Administrator Shah has emphasized, we have the tools to ensure no mother or child dies from preventable causes in this generation. This is also the second pillar of the U.S. strategy in global health. And both are worthy post-MDG goals, ambitious dreams. And these goals are realistic. Look at what we have done already so far as a global health community. HIV incidence has been declining since 1997, from 3.5 to 2.5 million and going down. Once the number of new cases is lower than the number of deaths, the AIDS epidemic will enter a self-reinforcing period of contraction. So this is not far, the different models, but clearly we are getting there. And since the founding of USAID by President Kennedy 50 years ago, child mortality has declined by 70%, and the decline is accelerating more recently, faster than when the Europeans did it 100 years ago. So, and we also know that just in the last 20 years alone, we have helped save over 50 million children's lives. Fertility has dropped as well, from over 6 children per woman in the 1960s to 3 or so in the developing world, excluding China, contributing to an improved period of maternal mortality, child health. Future generations, I think, will look back to this period as a turning point in the history of public health. And I could say in the history of civilization. And we are worried about our budget of next year, the next 20%, but looking in the big picture, it's truly an incredible time for the work we do. USAID's contribution to this peaceful revolution in human progress has enjoyed bipartisan support, the engagement of multiple U.S. government agencies, and the participation of civil society and the private sector. The American people and everyone here can and should feel very proud of the part that you have played in achieving this extraordinary accomplishment, and for U.S. global health leadership also moving forward. But our job is far from done. We know that. Although I believe there are indications that we are closer than ever before to narrowing the gap between our ideals and the reality at this time. Over 7 million children die every year, mostly in developing countries and mostly from preventable causes. If global under-5 mortality rates are brought down to the levels found in OECD countries, eliminating all disparities and so virtually all preventable deaths, the number will be about 1 million. So how do we go from 7 to 1? We are working on that. Given recent declines, it is a matter of time before we can reach that magic number that erases preventable death and equalizes rich and poor countries. We're working with Chris Murray and others in our teams and UNICEF to get to that number, because if we can see when we're going to get to that end of the tunnel for something like this, that should be encouraging for all of us. This is the grand opportunity for our community. We know it is not going to be a simple game of foreign assistance. but increasing country ownership and the health systems to ensure and sustain those gains. USAID, with other U.S. government agencies and global and country partners, will work to capture this moment in history to save lives, create a generation of healthy kids by saving lives at birth, and end most preventable child deaths. Indeed, the third pillar of the U.S. government strategy in global health is challenging the world and ourselves to work in new ways. Health systems will be at the heart of this global challenge, providing not only medical care and public health services, but also financial protection. So I hope to share with you today three main themes. First, I will start recapping the work that USAID has been doing in health systems with many of you in over several decades. Second, we are at an inflection point in the economics of global health and beyond our budgets here in Washington, and we need to adapt to an environment of new challenges and new opportunities. Third, in our emerging strategic framework, the next chapter of USAID's effort in global health will include new platforms for health systems, and we want to share with you where we are in that planning. In partnership with many of you here, USAID has a long history in what we now call health system strengthening. Starting in 1972, USAID's support to the World Fertility Survey launched us on a continuing effort to improve data and users of data in the health sector. In 1974, we teamed with the Centers for Disease Control and Prevention to provide logistics management assistance to family planning programs, and later to support CDC's reproductive health surveys. In 1977, our Office for Population created the Resources for the Awareness of Population Impacts on Development, or RAPID, project, which combined hard data with microcomputer technology to present policymakers and policy options in real time. In the 1980s, the Office of Population launched several more projects to assist countries in gathering high-quality data. So data has been important, evidence is being crucial to our work, and yet we know is not sufficient. Analyzing policy gaps and strengthening management capacity in collaboration with the U.S. Bureau of the Census to improve demographic quality data. The Demographic Health Service in 1984 had been one of the most important of such pieces, but also Social Marketing for Change in 1984, tips and enterprise for private sector activities, family planning management training in 1985, family planning logistics management. So management became an important theme of the work in the 80s. Also in the 1980s, the Office of Health built capacity in planning and management for the twin engines of child survivals through REACH and PRECOR. These are the names of the big programs at the time. A special branch of the REACH immunization project focused on health financing, as was the beginning of our work, important work on that arena. Out of the REACH experience came the now well-known Health Financing and Sustainability Project, HSF. Many of you may have been involved with that in 1989. In the early 1990s, the global community embraced health sector reform, and our health office launched its Health Policy and Sector Reform Division. Bringing together its cross-cutting health systems project, HFS, rational pharmaceutical management, quality assurance, private sector initiatives. Also in the 1990s, the Office of Population initiated the Policy Project in 1995, Evaluation Program Impact 1991, Family Planning Leadership and Management, and so on. We continue to support the Demographic Health Service and the private sector and social marketing projects, and they begin to form themes for the work of USAID in health systems. By the early 2000s, with growing discontent in the development community with sector reform, we reconfigure our division to become the Health Systems Division. In the Population and Reproductive Health Office, we created the Policy Evaluation and Communications Divisions, and I have to just acknowledge that Robert, Bob, many here were involved in really leading those changes in USAID. In addition to expanding and reshaping the previously started activities, we launched the Deliver project for procurement of health commodities in the year 2000, and in 2005, the huge supply chain management systems to support the procurement of medicines and the PEPFAR and to strengthen countries' logistic systems. And we developed the Capacity Project in 2000 to address the massive human resources challenges in the developing world. So a lot of that is our history, and you have been part of that. I will talk a bit more about each of those in the framework of the building blocks that WHO has advocated. Many of you have been, again, drivers and partners in in various signature accomplishments in our work in health systems. In health service delivery, we pioneered the adaptation of modern quality improvement approaches in developing countries, as highlighted this year in the British Medical Journal. And very importantly, USAID has been a champion of using market forces for sustainable development, including social marketing, sustainable commercial health products, expanded private sector partnerships, new networks, and so on. Private sector in particular has gained so much prominence recently, and USAID has been there, as you know, all along. Human Resources for Health gained much momentum last decade, following the report of the Joe Learning Initiative on Human Resources for Health, which I happen to have managed at the Rockefeller Foundation, as well as the 2006 World Health Report, which then I was in charge of at the World Health Organization. The momentum that was gained was clear, but it was thanks in large part to the support that USAID brought to this arena through the capacity project. I remember feeling this injection quickly in early last decade, and more recently through the Capacity Plus project, with activities such as the action framework that many of you are familiar with, a collaboration of multilateral and bilateral agencies, donors, partners, countries, NGOs, the academic community, and the application at country level through the Global Health Workforce Alliance, although that's also now in the process of transition at WHO, if I understand correctly. More recently, USAID is developing the Human Resource Information Systems, or IRIS, a suite of 3 open source databases to track health worker training, certification, and licensure, manage and deploy personnel, and provide long-term health workforce modeling and planning. The databases are supported by a constellation of activities, including the formation of participatory stakeholder leadership groups and training in data-driven decision-making for strengthening health workforce. In the realm of health information, again, USAID has long supported the U.S. Bureau of the Census and USAID's Demographic and Health Service as a flagship, really, increasingly a flagship of the world. I cannot claim any credit. I just joined the agency, but I share with many of you, again, the sense that it has been an invaluable public good for the past quarter century, becoming a gold standard in household surveys, methodology, and the utilization by so many. They have been innovators in data collection, analysis, and dissemination, such as handheld devices for data capture, collection of biomarkers, application of geographical information systems, and offering web-based data compiler for access to these data sets, all open to anybody, as you know. And an epidemiologist friend of mine commented recently that if it was up to him, he will grant the DHS the Nobel Peace Prize. I really think that it's been a great flagship of the work. Related components also includes the AIDS indicator survey, the malaria indicator surveys, and a facility-based service provision assessment working with and through the Health Metrics Network and related partners. In medicines and technologies, it's a huge space for USAID, and the contributions are legion. Beyond its leadership in technology for development, our Global Health Toolkit, technical assistance, and new integrated capacity have dramatically improved supply chain management and the availability of contraceptives and essential medicines, reducing stockouts, even when it's the global funds of responsibility, supporting countries in so many ways throughout all of our portfolio. 10 years ago, when we were moving on AIDS treatment from the Rockefeller Foundation with a program based on women and family, it was the early days, and I didn't know anything about supply chains. I had just studied public health. They don't teach you supply chains. And it was so crucial, and it was so weak at the time in Africa. And it's just incredible how far things have come. First, in a very vertical way, but increasingly to these programs, strengthening the supply chains within countries and the capacity of their own governments to manage. USAID has also distinguished itself in the area of rational and cost-effective use of medicines, as well as strengthening national drug quality control laboratories in about 16 countries and improving regulatory capacity and functions. I'm also a newcomer to health financing, but I fell in love very quickly. It wasn't difficult also to find USAID's footprint all over this space. The national health accounts have been a crucial development for health systems evidence and advocacy. It has helped me understand health systems and help others also begin to frame way forwards. 100 countries use this approach to track health financing, and like the Demographic Health Service, the more recent national health accounts are gaining partners and country ownership very rapidly. And again, Karen and Bob here deserve a lot of credit, and those who helped them all along to move this is a very impressive accomplishment. Country teams are being fielded now to conduct data collection and data analysis with support of regional collaborative networks on health accounts. And USAID has been supporting also community-based health financing models like the mutuals throughout Africa. Such financial pools and schemes are now forming the basis for emboldening governments to move on national health insurance efforts. Governance and leadership, I believe that the stewardship function of the systems is central, a real control now, is paramount for planning, managing, and again, the stewardship of what is increasingly a mixed health system. USAID has supported this building block or control knob in several ways. The Virtual Leadership Development Program is a web-based management development network in operation since 2002 with nearly 2,000 participants from nearly 200 public and civil society teams in 42 countries. The health systems assessment approach developed in 2007 has been used by more than 20 countries. Maybe MSH has been involved with some of that, and is harmonized with emerging frameworks in areas such as health information systems and governance, and includes specific guidance on stakeholder engagements. The mark of an effective health systems is its ability to bring essential services to the last mile. While not a recognized building block in the WHO health system structure, community-based approaches are a key element of strong health systems and in the work of USAID. Communities are the logical locus for integrated service delivery and for effective social and behavioral change communications. Global Health has supported behavioral change communications for decades, beginning with the Population Communication Services in the 1970s and continue today with the sector-wide Sea Change project. And this is an area that Robert's also now leading under what we call implementation science in USAID. It is not hard by now to point out that we are at an inflection point in global health. The field used to be called tropical medicine, for those who were not around, although the school hasn't changed the name. And with the end of European colonialism in the 1960s in Africa and Asia, we became international health. And with the end of the Cold War in the 1990s, we became global health. We don't need to go into the details of each of those. They were very different, not only in the chronological sense, but in the way things were framed. The political economy guided the international and sector-specific behaviors of governments, civil societies, the private sector, in addition to changing demographic and epidemiological landscapes. Well, the political economy is changing again at a global scale. And I don't know whether the field will be rebaptized or not, but many things will be changing in our space, beyond the current budget issues where we're focusing, and beyond the Beltway and our nation's borders. The rapidly evolving nature of the global health sector and its context will require a large degree of flexibility, innovation, and an even greater degree of collaboration in the global health community in the years ahead, especially with the governments themselves and local communities. The epidemiologic transition is a byproduct itself of our child survival and family planning success to date, is manifesting itself with a pandemic of chronic, non-communicable disease like cancer, diabetes, cardiopulmonary disease, and concerns over road safety and injuries are bound to grow. So this is changing. These trends will require attention and progressive adjustments in our work and platforms to assist countries in monitoring and preventing these new pandemics. Effective social and behavior change messaging will be a key element of that response, and we see that as part of what the health systems need to be gearing up for. Official development assistance from governments, the money is also changing. The actual development assistance in general from multilateral organizations and bilateral organizations is no longer the primary driver for economic growth. In the 1960s, such assistance represented 70% of the capital flows going into developing countries. Today, because of the private sector growth and increased trade and domestic resources, remittances, and capital flows, it all amounts to just 13%. And 50 years ago, 70%, almost all USAID. Now 13%, only a quarter USAID. There are many implications for this fact going forward. Even as our development budgets keep growing, and I hope that the 2012 budget will allow us to grow a little bit, the game is changing in the world. In Busan, South Korea, early this month, Secretary Clinton noted that also some of our development investments may have substitution effects, which is something hard to recognize, crowding out local resources, and added that this economic shift is serving as a catalyst to spark self-sustaining progress, something that we also believe. There are other contextual developments, and we all know context is paramount to better health. I would like to take this opportunity to emphasize what I call the economic transition of health, and Karen is now working with a team with us, and we had touched on this early with others, on what it is and what the implications are. Despite the economic slowdown in OECD circles, developing countries are actually in the midst of an unprecedented economic expansion, driven by better governance, by the globalization of trade and technology, and also by the demographic dividend. The demographic dividend is brought about by family planning and child survival success in combination with rising girls' education and supportive economic policies. For families and nations, fewer children per woman translate to significant savings. While the demographic pyramid gets an expansion of its working age segment, further strengthened by empowered women joining the workforce. This demographic dividend adds 1 to 2 percentage points to the GDP of a country for a period of 30 years or more. We have seen this scenario unfolding in Latin America and among Asian tigers, and it is just beginning to unfold in Africa and elsewhere. Last week's Economist magazine reported that over a dozen African countries now have expanded by more than 6% for 6 or more years. And so we're going to have people are debating whether to call it the African lions, the African cheetahs, but it's all happening right now. Today, the world economy is 6 times bigger than it was in 1960, persistent inequalities notwithstanding. This is more than double the growth of the population. So the average income per capita has been growing significantly for the first time in history in the last 30, 40 years. Countries that were once aid recipients are now amongst our major trading partners, as well as participants in a new emerging aid scale. For many developing countries, and quotation developing countries, from India to Nigeria to Philippines and Uzbekistan, the $50 per capita cost of a basic health package represents only 10% or less of the additional per capita income projected between 2009 and 2012. As economies grow, dependency on foreign aid will decline. Mozambique, for example, just announced that only 39% of the public expenditure in 2012 will be covered from foreign grants and loans, compared with 45% this year, 51% last year, and many of you know it was even higher a couple of years ago. So how do these developments affect health in those countries? And how should we adjust to these shifting patterns of economic growth? If experience elsewhere holds true, these countries will invest the proceeds from growth disproportionately in health. That is, health expenditure will tend to grow faster than the GDP of countries. The income elasticity of demand, as the economists will call it, it holds above 1, even among low and middle income countries, although attenuates in the poorest countries. By the end of this decade, domestic health spending may actually double in many of the USAID partner countries. I mean, it's not surprising that while USAID was working in over 100 countries, we have shrunk to about 80 countries. We're now moving to 70 countries. We're concentrating in 30 countries. This is just a result of success. And it's a success that I don't think we have framed very well as a community. Maybe some were afraid to. Of course, there's still so much to be done, but also afraid that may impact the mobilization of resources in support for our causes. And yet, I think it is important. And yet, the default for this growth in developing countries in the health sector tends to be an expansion of unregulated private provision and out-of-pocket payments. which now accounts for 50 to 80% of total health spending in Africa and Asia, according to our national health accounts. Such a default scenario leads to systems inefficiencies, inequitable access, and catastrophic expenditures across all health conditions, old and new. As reported in last year's World Health Report, every year 100 million people are pushed back into poverty by health bills because they lack prepayment schemes. It is now paying for health bills the #1 cause of people going back into poverty in the world, and it's also the #1 cause of personal bankruptcies in this country. This cannot be the future of health, especially when growing economies should afford better health for all without families having to go bankrupt. So how do we turn this challenge into an opportunity? At USAID, we are exploring, like others, how to engage BRICS countries at the end of this spectrum and other emerging economic powerhouses as strategic donors, and as stressed by Secretary Clinton and President Obama, and we will be doing more of that in the future. We're also discussing, where feasible, how to crowd back in local investments from governments and appropriate markets as part of our country ownership and graduation strategies. We certainly have crowded out some countries with some of our investments in AIDS, malaria, immunizations. These are well documented. So how do we get that dance going in a careful way in the next few years? Especially since in many countries we eventually end up doing it anyway, and so it's better if we learn to have a way to do this well. And finally, we are working on how we can support health financing reform to extend coverage and decrease out-of-pocket expenditure to reasonable and equitable levels throughout the developing countries. So these are many hard questions, and I hope that you can help us in the discussion phase. This brings us to the last theme of the presentation tonight, the way forward. We are finalizing USAID's strategic framework for global health. A draft has been circulated to U.S. government agencies for comment. Today is the deadline for that, so I hope to get all of that. I'm very interested also today in hearing your ideas and suggestions on how we are looking, or the outlook that we are having on the strategy. The document is our effort to align the dynamic and complex set of national policies, directives, initiatives, and other factors that influence our operations into a cohesive approach that will communicate and guide a well-informed and strategic global health response. USAID's strategic vision is inspired by and aligned with the principles and goals of President Obama's Global Health Initiative and USAID forwards reforms in the agencies. One of the principles, as you know, of GHI is strengthening health systems, and Joe Nemoli here has been driving not only our strategy but also the interagency strategy for health systems in the U.S. government. It's almost done. As Administrator Shah, it's also organizational changes at USAID, and that goes by the name of USAID Forward. And Administrator Shah has remarked, USAID is aggressively doing its part to usher in a new era for our agency. And we understand we are in sort of a third act of this historical development story. Through procurement reform, we are almost doubling staffers in countries, a lot of young people, almost 2/3, 60% have been with the agency within 3 years. So there's a change of guard taking place in USAID, a lot of young people, and a lot of mentoring, a lot of new ideas and ways of working. Also, procurement reform. That's one of the priorities for us, is beginning to invest more directly in countries, whether it's with governments or with local NGOs, as part of the strengthening, as part of the country ownership, a part of this larger transition. And we have very ambitious goals to do so. Everybody's busy trying to do that in the right way. It will still be a minority of the total expenditure of the agency, but it will amount to almost doubling that in countries. So plenty is happening under an ambitious transformation plan on how we do business, and something that has been recognized also this year by the OECD DAC peer review in a very positive way. USAID's strategic vision is guided by the principles and goals outlined in President Obama's Global Health Initiative. Since its launch in May 2009, significant progress has been made towards a more comprehensive global health strategy for America. I think GHI has already succeeded in that way, in bringing us to a more integrated way of looking at work. After some initial bumps in the road, as we all know, GHI is now fostering greater interagency coordination, country ownership, and smart service integration, while aligning previous health initiatives, namely the President's Malaria Initiative and PEPFAR, for greater efficiency. Portfolio reviews across each of our global priorities have opened up our thinking to external participation, while about 42 GHI country strategies are integrating U.S. government programs across health for improved collaboration and efficiencies. And it's really great to see many of those plans if you haven't taken a look. The GHI principles is the very ink for the historical signature of this initiative. And we are now working in operationalizing those principles through papers that will be in consultation, I hope, following appropriate regulations for that. That will be systematically implemented by U.S. government teams on the ground. Service integration is one of them, country ownership, sustainability, health system strengthening, gender, and the like. The substantive portfolio at USAID spans many crucial areas for the health of poor people, from family planning to tuberculosis control. Our 5-year success, nonetheless, will be measured, number one, by our contributions to saving lives among those poor and vulnerable people, particularly mothers and children. Number two, by our ability to strengthen health systems and foster country ownership. And number three, by inclusive leadership in global health and international development. The current budget environment will require us to do our work with even greater efficiency and lower cost, while engaging new partnerships and fostering country ownership and sustainability. As I've said before, we cannot solve the challenge of our times unless we solve them together. With that wider perspective as background, I want to discuss our renewed effort to address countries' needs for strong health systems. The Global Health Initiative and Administrator Cha's organizational reform efforts compel and enable us to work in new ways that are more efficient and foster greater country ownership. The principle of GHI in particular will enshrine the importance of health systems, and we are taking this as an opportunity. GHI's call for country ownership and sustainability means greater capacity for mixed systems, health financing reform, and smart integration of health services. This means providing easier access at a single location for a broader set of health interventions. It means making the shift from disease-centric model of care to a model that focuses on the needs of the patients, of people. As non-communicable diseases emerge as new killers of poor people, we can leverage community and facility-level platforms to combat smoking and address basic prevention needs. We're also making sure that DHS will cover smoking, obesity, and the like. We can encourage greater domestic investments in and ownership of integrated health systems to ensure better access for all to appropriate health services at an affordable cost. USAID has developed a strategy for health system strengthening, and again, thanks to Joe and the network throughout the sector that builds on our long-standing investments, made with your support and ideas, and also will challenge us to address some of the more difficult health systems problems facing countries today. We are in the midst of establishing a dedicated office for health systems work, and I've been warned that it's not an easy task to do in a bureaucracy, but I believe it's the right time for this to happen. And so I also want to acknowledge our teams here, many from USAID, who have been working in making sure this gets done. And we are quite advanced, I have to report to you, even though it's only a short period of time working on this. A testimony again to the demand. Some people know to some of the HS 2020, the demand by bilateral demand from countries have grown 10 years ago, 5 countries, 5 years ago, 20 countries, now 50 countries. So clearly, we need to gear up for this growing demand. And at the World Health Assembly this year, after a resolution encouraging health financing reforms towards universal coverage, there were like 50 countries stepping up the plate, and our friends in the health financing group don't know what to do with that demand. Really, it's going to be a growing space. So we are working on this office as something that will help us serve as a center of excellence and a focal point in providing worldwide leadership and technical expertise in health system strengthening. Using a network model to engage the technical expertise and portfolios of the other offices in global health, in our regional bureaus, and in our missions, the office will be responsible for coordinating global leadership and strategy, knowledge and talent management, and field and program support. The office will lead the development of USAID cross-cutting agendas and strategies to promote effective, sustainable, and country-owned health systems capable of advancing GHI targets and addressing emerging public health priorities. This new office will lead the agency's cross-cutting health systems research efforts, including development of a research portfolio and on metrics and tools for measuring health systems improvements. It will track and work to align USAID resources, funds, and programs for health system strengthening with this agenda. The office will also work to influence the priority of others to support this agenda and strategy, including other U.S. government agencies, host country governments, donors, firms, and civil society. We need you all to succeed in that. The Health Systems Office will be USAID's hub for capturing and sharing state-of-the-art knowledge. There's a lot of lessons from our own work, and we need to really bring them all and share. On factors that contribute to strengthening health systems, including those that in the domains of complex systems thinking, service delivery, community engagement, governance, finance, etc. The office will work with other offices in the Bureau, missions, and regional bureaus and partners to advance health system strengthening knowledge as a whole for the global community and innovations to promote country uptake. The office will also house a critical mass of health system specialists and serve as the hub of USAID's talent management in health system strengthening. It will work to grow and nurture USAID's technical expertise and intellectual capital in health system strengthening within USAID's for our bureau, missions, and regional bureaus. We have a huge machinery for training and staff professional development, and health systems will become central to that. As you know, we are a decentralized agency, and the heart of USAID's work is in countries and our budgets too. To support field missions, the office will work with our country support office, other GH global health offices, and regional bureaus to ensure that expert technical support in health system strengthening is available to missions for this area, strategy development, project designs, monitoring, and evaluation. Where they are not available elsewhere in our agency, this Office for Health Systems will also develop and manage central program mechanisms such as partnerships, grants, cooperative agreements, and contracts that are essential to enable USAID to achieve its vision of effective, sustainable country-owned health systems. Again, we are not there yet, but you are the first to learn really outside USAID of these efforts, and I believe you are a community that deserves to know and deserve to help us make this office a success. So to conclude, investments in global health are a pillar of American leadership, advancing our national interests, making our countries more stable, and the U.S. more secure. They are a fundamental expression of the values of Americans. We have made incredible progress in international development and global health in recent decades, and a crop of recent demographic health surveys results give us cause for optimism, even in Afghanistan. We can now envision near zero deaths among children and mothers, as well as an AIDS-free generation. This generation will do that. The world of global health is changing with the political economy, as we noted, and we will continue to adapt to a changing budget environment by becoming more efficient with the resources that we do have available, and by challenging the world to see through the development revolution initiated by President Kennedy 50 years ago. The Presidential Policy Directives, QDDR, USAID Forward, and the Global Health Initiative position us to maintain momentum and move forward with game-changing innovations and better health systems as countries ride this economic transition of health. But delivering effective aids is a two-way street. It requires leadership from our partners and many other formal and informal actors to save lives, unlock opportunities, and deliver meaningful results to the poorest around the world. Many countries in Africa and Asia are in the midst of an economic transition of health that will bring challenges and opportunities to our work for better health and financial protection. Our 5-year success will be measured again by our contribution to saving lives, strengthening health systems, and inclusive leadership. USAID's new strategy on health systems will build on decades of accomplishments to seize this new momentum and contribute to global leadership, better knowledge, and greater support to our partner countries in this very important area. We all very much look forward to working with you and with many of your networks in this new era for global health. So I thank you and look forward to your questions.
Thank you very much. So, Ariel, I think you've provided us with a lot of fresh and extremely challenging ideas when we think about the implications of economic growth and the shift in balance of power between countries for development assistance and the role that it needs to play in the future, as well as the emerging epidemiological transition and the implications of that. And you've asked us really to challenge ourselves to think about how we can strengthen health systems and the role of development agencies such as USAID in strengthening health systems, which I think is really a challenging set of issues.